So, for our first interview, we interviewed Dr. Yonis Jabril Hassan, who is working at Mount Sinai as a child and adolescent psychiatric resident. And he has a lot of experience working in the emergency room. And so we got some really great insight, and I'm just going to kind of break down the interview since he didn't have time to do it in person, so we just decided to conduct email interviews. So when I asked him about his definition of competence in terms of evaluating someone for being mentally competent, he gave me a specific table that he goes by, and he quotes, "It is the gold standard." And it's pretty much, there's a decision that needs to be made and an intervention that needs to be implemented. And he uses this table to figure out who should be deemed competent or not. But I'll get into his definition of competence in a little bit. A lot of his answer was about the inconsistencies he's encountered with involuntary admissions, specifically the ethical inconsistencies. He believes that, especially where he's working in Manhattan, the income gaps really depicts or illustrates itself in the emergency room. He thinks that appearance is a huge factor that goes into this. For example, he says, "This is an issue in the sense that I've seen the staff get hit by a person who I will describe as a wealthy appearing businessman with a very involved family, and thus the staff felt either more sympathetic or less inclined to make quick and personal decision to restrain and medicate, a bias that led to a poor outcome." And I think that's really, really interesting, because later he says, again, involuntary admission experience may be more positive for those who appear to be of higher wealth, social class, or white appearing versus someone who may be poor, homeless, or who spoke English as a second language. And that was just something that really opened my eyes, because I didn't really think about that. And yeah, so moving into the third, talking about how the majority of patients who are involuntary admitted opposed to admission, he talked about how there's a lack of psychiatric beds and how some patients are able to verbalize some things, and sometimes those things are important and can really help the doctors, but there are also times that the voluntary admission and them wanting to be admitted for their mental health are rejected or denied because they have a lack of beds. And this leads to prioritization of those severe mental illnesses, the severe suicidal, psychotic, and manic episodes. I really thought it was interesting how he talked about being too sick or not sick enough. I think this is a huge ethical factor within the psychiatric field. When someone's dealing with mental health, it can be really hard because there's no physical sign of someone struggling. I mean, yes, there's a physical sign, but when you have cancer, you have treatment. When you break your bone, you put a cast on. With mental illness, it can be really hard because there are so many different treatments, and sometimes a lot of people don't believe in what they are. So mental health treatment, he says, feels like a constant battle for those seeking care, of whether being told you're too sick or you're not sick enough. For question 4, talking about if a person has to be diagnosed with a mental health disorder to be involuntarily admitted, he says it's tentative, so it's able to change. And I made note of this because this really relates to the sliding competence scale of how someone may have a diagnosis and over several days it changes. So he says, for example, psychosis secondary to substance intoxication versus a primary psychotic disorder cannot be differentiated upon initial psychiatric emergency room assessment, but over several days. How patients respond to the meds over the next couple of days as substance-induced psychosis usually clears faster. Also, he noted that insurance requires a diagnosis, which is a very valid point, especially when relating this to the income gap, because not everyone has medical insurance and not everyone is able to access the care that they need. We're talking about the correlation between involuntary admission and their recovery. Something that Dr. Hassan talks about a lot within his interview is acute processes, specifically acute mania, acute psychosis, and acute suicidal plan or intent. And he believes that for those who are struggling with that acute processes, they will see a more improved result after being involuntarily admitted, opposed to those who may be suffering with borderline personality disorder or severe chronic PTSD symptoms, because they're more related to social factors that cannot be immediately rectified, he says. And another mention was about outpatient services and what those people can have access to outside of the immediate emergency care that they're looking for. For helping someone ethically and wondering if there's a more ethical way to help them rather than just putting them in a psych ward involuntarily, he does believe that there is a better way. The example he gives in response to number 8 is that if a person is not actually acutely suicidal, acutely psychotic, or acutely manic, again, with the acute processes, which I think is a huge thing that he told me was harped on in medical school, there's not a clear reason for the involuntary admission or the clear treatment that they can offer in 7 to 14 days. Then the risk of inpatient hospitalization against their will, such as loss of autonomy, lack of trust in the medical system, risk of becoming institutionalized. He thinks it is not worth it and that they should proceed to find the outpatient care if applicable, if possible, if they have the money and the financial resources to do that. And that's another thing that comes up and how it's really hard with, especially in being in New York City, and I'm sure over many, many places in the world with the income gaps. I think that another thing Dr. Hassan talks about is the trauma aspect of this. And I don't think this is spoken about enough because, I mean, it is crazy how much the psychiatric care and psychological mental illness, how it's evolved so much over the years. But the trauma that these individuals go through is intense and it is real. And I think that sometimes it is really downplayed and looked down upon. But he mentions that it is not worth it to risk, like I just said, risk against their will to have a lack of autonomy or to have that trauma or have a lack of trust or don't have that rapport with your whoever is admitting you. And then for if his education within medical school has prepared him, and how competence plays a role and if he's heard of the sliding competence scale, because that's really what the focus of our project is on, specifically regarding the involuntary admission. But I think it's really important that not only should the sliding competence scale apply to different individuals and different diagnoses, but also within a person. They can have competence one day and not be competent 10 minutes later because they're experiencing a psychiatric episode. But he also doesn't believe that there is no universal, they do have competence or they don't have competence, which I think is really interesting because I think some other doctors, or you'll hear Mrs. Hannah Beerson's opinion on everything or perspective on everything later, but it's really interesting when some people say that there is none and some people do. So the example that he gives about a person refusing a specific recommendation intervention while not having competence to refuse another is a person can have competence to refuse a routine low-risk procedure if they can demonstrate why they do not want it and that they know the risk. A person with low medical literacy or mild psychosis will probably say, "Don't poke me, I don't care if I end up delaying my diagnosis of something." And the doctor will respond and be like, "Okay, fine." He says, "It is like checking something that won't change the course of treatment much. However, a life-threatening illness with a low-risk treatment would require a way higher literacy and a very lucid person." So if someone comes into the doctor and says, "Yes, you may do this low-risk procedure," it's very different if they are experiencing a psychotic episode and have to be undergoing this crazy procedure. Finally, I'm going to talk about what he harped on regarding question 2, which is the ethical issues and inconsistencies he's countered within his profession dealing with involuntary admission. And he refers to the novel Of Two Minds by Jory Post. And he says he had to read this book for class, and when he was in psychiatry residency, and he says that anyone manic or psychotic in the psychiatric ER who won't accept offer of oral medication should get an injection, as this is a curative, indicative treatment that they will ultimately feel so much better. So he's saying he's nothing wrong with this injection, which I think is super interesting. But he does have an issue with trauma and how people develop this trauma, like I mentioned before, by being locked up in a unit and they just act and scream out, and it's like you can do nothing for them. But he thinks that there's a better alternative. And so part of this alternative is injecting this into whoever is dealing with this acute psychotic episode. And in the book, this is the paragraph he referenced. "Still, I entered my psychiatry rotation with contempt for psychopharmacology." Excuse me, I don't really know how to say it, but within 3 days, I remember this guy in from the street, absolutely psychotic. His mind was splattered on the wall. He came swinging onto the ward, everyone's tugging on their necklines, and he gets an injection of Haldol. And within an hour, and that is an antipsychotic, and within an hour and a half, he was a normal human being again. Idiosyncratic, mind you, but making sense in an own way. And I was stunned, absolutely stunned, that a very simple and intrinsically uninteresting intervention could be so dramatically transform the subjective universe. I had been completely in this psychodynamic camp, and this just woke me up to the fact that there is other dimension, and it is real, it is concrete. And I think that this is also so important, and Dr. Hassan continued to talk to me about this, and that not only the world, as I'm like a super existential person, but the field of psychiatry and psychology is growing so much and has been so much more normalized and has so much more press and is just talked about a lot more. And the fact that we're able to learn something new every single day and from a different patient, and how all different patients have bring so much learning to doctors as well, that this is so interesting because you can hear it and you can listen to it, and I can be talking about this right now, but deep down I'm like, oh, could this, like, how does this work? Like, how, but it's just how our brains are wired. But yeah, I hope this little reflection was a good outline of Dr. Hassan's interview, and I'm very grateful to him for taking the time to respond to me and go back and forth over email. And yeah, see you in the next one.